from the Faculty of Pharmacy and Pharmaceutical Sciences, University of Alberta in Edmonton, Canada. She's also the founder and manager of AdX Health Services Limited in Saskatchewan. I hope I pronounce it right, Saskatchewan. So yeah, Professor Dalia, go ahead. You have 20 minutes.
Thank you so much, Dr. Ahmed. And yeah, I'm really glad to be here among all my professors and colleagues. And actually, pharmacogenomics is one of, you know, I started very early in pharmacogenomics as a passion. That was back in 2012 when I wanted to start giving that to my students in the undergrads. But since then, the science has developed so much. And what I can say about here is yesterday's presentations gave a good introduction to what's the meaning of pharmacogenomics. So today I'm not gonna go deep into the introduction, but rather the applicability. My talk today would be about the pharmacogenomics, a pathway towards precision medicine, and I'm concerned about the applications in community pharmacy in Canada, as an example. Okay. So I'm going to be covering a slight introduction on pharmacogenomics and precision medicine. And as I mentioned, I'm not going to focus so much on this portion because it has been covered yesterday. I'm going to talk about the scope of practice in Alberta, Canada as a model for community pharmacy. So what are the expectations in a community pharmacy? And I'm going to cover the whole scope of practice. And then we're going to talk about how to implement, or how we did actually start implementing pharmacogenomic services in community pharmacy. I'm going to talk about the utmost or the best model that we should see. I have to say that worldwide, this model is at its beginnings. We're not, like in Egypt, we're not that far behind. And even in Canada, we're striving to get better and better over time. But at least over here, we did start practicing the pharmacogenomic services in the pharmacy. Pharmacogenomics and therapy management. And finally, I'm going to touch base on some clinical aspects on how to actually utilize pharmacogenomics in the therapy management. So pharmacogenomics is a new discipline that studies the effect of DNA variation. So basically, and yesterday, Dr. Hiba discussed about the DNA variations. She spoke about the SNP or SNP, single nucleotide polymorphisms, and what is the difference between pharmacogenetics and pharmacogenomics. And so basically the DNA variations would result in alterations on the drug behavior inside the body, whether at the metabolism or the clearance level, and by that it's affecting the pharmacokinetics of the drug, or if it affects the activity or the effectiveness, if it affects a transporter, or if it affects a receptor or something like that. So basically, it will end up affecting the activity or the end results of the drug, which is the PD of the drug. So basically, pharmacogenomics can make changes in the PK and the PD of the drug, as such resulting in a different behavior of the drug. And this is where we say this is a new add-on to whatever we're having. So when we say personalized medicine, we want actually to move from the idea of the empiric therapy or one dose fits all over here to dividing people into groups that share similar characteristics. And based on those similar characteristics, we start personalizing those medication to each bunch of group over here. Now, the question is, do we actually, is personalized medicine or precision medicine something that is brand new? I wouldn't say that. I would say there is a new cofactor added in here, which what we call drug-gene interaction, which is the changes in the DNA variations that affects the behavior of the drug. So this is drug-gene interaction. This is the new term that we're presenting today with the idea of the pharmacogenomics. The drug-gene interaction has to be added to the drug-drug interactions, has to be added to the liver function, has to be added to the kidney function, has to be added to the other cofactors, age, gender, you know, all the other parameters in which we use the TDM, the narrowtherapeutic window, all the other parameters need to be added. It's another cofactor in order to make a personalized or precision medicine. Now, the community pharmacy in Alberta has a wide scope, okay? And for this wide scope to be applied in full, you need appropriate license for each scope, you need appropriate training to be accepted, and you need a physical space and tools to be able to apply all the scope of practice that I'm mentioning. So not every pharmacy in Canada is actually doing all of those things. You need the license, the training, the space, and the tools in order to be able to practice the scope to the full. So in the community pharmacy in Alberta, we have the medication dispensing as usual. This usually occurs through a pharmacy operating system. And in the pharmacy operating system, we carry the patient information, we carry their drug history. The pharmacy operating system is expected to give you the drug-drug interaction alerts and all those things. We have the OTC consultation and advice. So basically, when a patient comes for an OTC medication, something that is not prescribed, the pharmacist and the pharmacy technician are ready to help and guide them towards the OTC consultation and give the advice. Drug compounding, and drug compounding recently has went through some advances. And in the drug compounding, basically a patient would come in with a prescription that is not found on a large scale manufacturing level, and the pharmacist would have their own recipes or their own formulations. And after having the appropriate approved special space and appropriate approved special tools and the training, they are making the small dose suspensions, sterile and non-sterile products, capsules, tablets, depends on the scope and the license that this pharmacy is having. The other thing is the point of testing. So we can do a pharmacogenomic testing in a community pharmacy. We can do strep throat testing in a community pharmacy, UTI testing, urinary tract infection. COVID testing recently was done also in a community pharmacy and others. So a community pharmacy can act as a point of testing. Clinical service, and clinical services include travel vaccination advice. So people who are traveling, the pharmacist usually visit the CDC websites, check the vaccinations that the patient should be having, start giving advice for the pharmacist. And travel vaccinations can also need license to be a travel vaccination center as a community pharmacy. And some of the things are done, without it. So basically for travelers' diarrhea, for, the big main things. Afterwards, it's the therapy management. And when I talk about therapy management, means that I get a list of all the patients and I start making a plan for the patient. Those are clinical plans that are done within a community pharmacy to guide the patient to whatever is happening. We also give injections inside the pharmacy. The injections in Canada are only within the intramuscular or subcutaneous injection, and also they require a specific license and training. Pharmacists in Alberta have some prescribing powers, and this is something that the other provinces are trying to catch up with Alberta with. And prescribing pharmacist, to be a prescribing pharmacist, you need also to get a specific license for that. And like that, you can actually visit the guidelines, diagnose a patient on a smaller level for some of the minor elements or some of the things that the pharmacist would be more comfortable with the idea of prescribing at this level. And they do send eventually the patients to the lab through lab requisitions, and they follow up on the results because the patient's data for the whole province are found on a national level. It's called the NetCare, where all the healthcare professional can access the NetCare through a specific license and follow up on what the patient did in a hospital, what the patient did in a diagnostic imaging, what the patient did in the laboratory results, what a patient last dispensed even from another pharmacy. So everything would be out there on the NetCare. If the patient entered the emergency room, for example, what are the outcomes of this emergency and what happened over there? So when you see your patient in front of you, you can actually follow up on everything that is happening related to the patient. And finally, communication with other healthcare providers. The pharmacist is always faxing other doctors over the phone, taking verbal prescriptions, modifying the dose and sending back to the prescriber, doing the therapy management and sending back to the doctors. So it's a whole, and the nurses, of course, and so it's a whole process. Now, if we're talking about within the scope, I mentioned that the pharmacogenomic testing was one of the was among the points of testing. So basically, I can use a community pharmacy as a point of testing for a pharmacogenomic testing. Okay, pharmacogenomic testing as a point of testing in a pharmacy is a new service, and only for now in limited places. We're trying to increase this service. We have some hindrance or some challenges, but this is not the time to talk about the different challenges. I'm going to talk about if I'm a new pharmacy and I want to implement the pharmacogenomic testing, what do I need to do? So I need to first to choose or to get to choose the company for which I'm going to be the point of testing for. This company would give me and give my staff training, a company training. Okay. From my point of view, this company training is sort of a refresher, and the material of pharmacogenomics needs to be embedded in a high level in the undergraduate for all pharmacists. Okay, this is how I see it, and this is what we are applying now in Alberta. Starting the documentation system in the pharmacy and consent forms. So the company, after giving you the license, after giving you the training, are going to give you their consent forms. Their consent forms has to follow certain ethical and legal parameters. That is, we do teach that to our undergrad students. Okay? We have to start documentation in the pharmacy. Where are we going to keep those consent forms? Where are we going to keep the patient's data? How ethical and legal, and how can we manage this data? And then the next portion is to identify eligible patient. Who is the patient for whom I should send to do the pharmacogenomic testing, and who is the patient whom I don't? And why do I have to make this choice? Because this is an expensive thing. The pharmacogenomic testings with I'm talking about the commercial kits, costs between 150 Canadian dollars up to 2,000 Canadian dollars, okay, which is something that needs to be thought, because most of the insurance companies until the specific moment and the governmental bodies do not cover those tests. Because we don't have enough studies to prove the cost efficacy and what are the benefits of those versus if we don't do those tests. Okay, we have to talk about we would have to talk with the patient about the pre-test counseling and the post-test counseling. So before the patient signs in the consent form and we do the test for the patient, we have actually to sit with this patient. We have to discuss with them some ethical and legal. What are the risks that they are going through? For the commercial kits that we're dealing with in the pharmacy, those are for therapeutic purposes. And for therapeutic purposes, you're only measuring transporters, enzymes, receptors, okay? That basically the results or the outcomes of that is going to be used for dose adjustment or dose modification. The pre-testing that a pharmacist would do in a diagnostic testing or the PGX that is done for diagnostic testing is totally different, because there are some ethical concerns in here talking about, can the patient live with the idea that they are carrying a certain gene that would make them more prone for certain diseases? Would the patient have the courage to speak with his family members that are surely to have similar scenarios and warn them about themselves too having such things? Those things the patient has to be aware of what he's going through before he signs this consent and this contract. Okay? For the commercial ones, there is another parameters that we need to worry about, and those are the new terms: genetic stigmatization and genetic discrimination. And those are the future things that the legalizations out there, the GENA and the GINA, has been issued towards to prevent them. And what does that mean? It means that if the data are handled in a wrong way, and the data are not managed and not kept in secret and not released unless the patient has released them, then basically we're having the idea of the patient being deprived or getting an appropriate job, because if the employer gets the information, he might not give him the job, or the insurance company refused to give him insurance or coverage because he is more prone or he's carrying certain genes. So the DNA data has to be handled with very much carefulness, and we need to be careful and we need to advise the patient before doing the test about the risks if the data is not handled and managed correctly. Okay. After we do the pre-testing counseling and post-testing counseling, we receive the results, and the results come usually from the company done by PharmD colleagues, and the results are very thoroughly managed, telling you which medication he should take, which medication he needs to change dose. We have to keep in mind that we're doing a therapy management. We're not doing a drug-gene interaction therapy. Okay, drug-gene interaction is another covariate to the things that you have to do for your patient. So basically, for this, as a pharmacist and as a healthcare provider, you need to sit down, you need to add the data that you got from this result to the already data that you have. Is he elderly, within the elderly population? Is he having proper kidney function, proper liver function, etc., etc.? Based on that, you add the new covariate and you start talking with the patient and communicating with other healthcare provider only if the patients give you the approval, because the data, the genetic data, belongs to it or owned by its owner only, owned by the patient, and you're not supposed to share the information unless the patient gives you a written consent and a written approval for you to do that. So this is the ethical and legal consideration I was talking about. The data storage has to be very careful. Each company provides the data in a certain way. So some companies give you a hard copy. Other companies, or most companies, have online thing in which you access this online thing and get the data from there. And the data are managed on their portals and their websites. The data storage stays for how long? Usually 10 years. And the sample is usually kept for 10 years. And all those specific data is written in the consent, at which you have to go with the patient on every single aspect at the very beginning before doing the test and explain thoroughly to the patient so that the patient is aware of what they are doing. And then incorporation in current patient therapy management plans, as I mentioned, so when you add it as another covariate, not as the sole covariate of adjusting the dose. And this is what we call precision medicine. Okay. How many companies are there? About 15 to 20 companies that are available within the Canadian and the US markets. Some of them allow the patient to go and buy the kit by themselves over the online, okay, and they send him the thing and they do the tests. Some actually refuse releasing the test unless that they get a prescription from a pharmacist or from a doctor. Some of them are recreational, that do your ancestry in addition to some of the some of the pharmacogenomic like receptors or transporters, things like that. The things that we need to be aware of is that the results are very hard to interpret. I have seen some of the recreational reports, and it's not fair for the patients to go through this data. It's very much complicated, very much professional data that it needs a pharmacist or on the board. It needs a person that understands what does this mean and explain it roughly to the patient and keep it on their profile for any future cases as well. Okay. So what are we testing? We are testing SNPs, single nucleotide polymorphisms, or genetic alleles that occurs in and results in changes in the proteins of the transporters, of the enzymes, of the receptors. The enzymes, and those are the ones that are found commercially. So you'll find CYP, cytochrome P450 enzymes, most famous of which are 2D6, 2C19, 2C9, 3E4, 3E5. Okay, you will find some receptors like the SILCO1B1. You will find some things that relates to the VK-ROC. There is also the mu receptors for the opioids. So you will find the receptors, you will find transporters. Those are all found within the commercial kits. Depending which commercial kit you're using, how much are you paying for it, all those are the things that we're looking at. As we can all imagine, if I'm having a transporter or a gene or an enzyme that works in a different pattern, whether overwork or less working or totally inhibited, that doesn't work at all, then basically I'm having an altered PK, an altered PD, and eventually I have to adjust the dose accordingly. The labs, the actual labs that do the analysis of those samples are found in Australia, in US, and some in Europe. Okay, so basically we do the sample in the pharmacy, we send it to their representative in Canada, and this representative send it to whatever lab that it's supposed to be. The results are usually between around 3 weeks, around the 3 weeks, 10 to 15 business days. Now, as a pharmacist, what can I do? There are some guidelines and resources. We know there is for example, in Canada, we have the e-therapeutics. There is the up-to-date, we have the Lexi, we have different resources for dosage adjustment and dosage modifications. As pharmacists, we go and revise those things. So what are the guidelines, the resources that we need to look at for drug-gene interaction? We have PharmGKB, and the guidelines are usually CPIC. CPIC is another website. So we have the CPIC, we have the Dutch group, we have the Canadian group. Those are among different groups that do actually put some guidelines to deal with the case that we're dealing with.
And Dr. Dalia, we are running out of time. You can have 2-3 minutes extra.
Sure, I'll try to finish within that. Thank you, Dr. Ahmed. As I mentioned, the CYP2D6, you can check the amount of medications that the CYP2D6 is involved in. The CYP2C9, you can check all the medications, CYP2C19s. If you look at that, you will find that the polymorphism or the pharmacogenomics affect all aspects, not only opioids, not only antipsychotics, not only cardiovasculars or warfarin or the big thing. As pharmacists, this is the future because it's involved in every single medication that we are prescribing. It can stop, it can make a failure in H. pylori therapy. It can make a failure in antipsychotics therapy or antidepressants. It can make a failure in pain management, okay? So as you see, it can make even problems with the NSAIDs. Can you imagine like the OTC things, like the ibuprofen that is found OTC, patients can get side effects if they are even dealing with NSAIDs because of their genetic profile. Those are things that Dr. Heba even mentioned yesterday. The enzymes would be either poor metabolizers, intermediate, extensive, and ultra-rapid. Those are very nice terms to eventually get used to and accommodated with, because this is something that you're going to read a lot. Again, this is an example of a patient coming in a pharmacy. He's having a failure in pain management. He's having side effects to the antipsychotics, and he's having problem with the GERD. And he needs to figure out, would the drug-gene interaction cover that or help him with that or not, okay? I won't go into this because there is not a time, but this is an example of how the report would look like, okay? Showing that this is the patient's, for example, gene, and this is the genotype he's carrying, and this is the phenotype or the activity or the functionality accompanied by this genotype. But how would this be integrated and how would this be interpreted into your own therapy management? You have to visit your profile, you have to visit your guidelines, the guideline groups that I mentioned, okay? And then based on that, you have to adjust the therapy accordingly. Okay, and after the drug-gene interaction, you need to sit with the patient, discuss everything, and you don't stop at that at the community level. You have to tell him even about the future possibilities of drug-gene interactions. I think at this moment, I'm done with my talk. If I want to talk, as I mentioned, it's a lot of passion. If I want to talk about pharmacogenomics, I won't stop, but I will stop here, Dr. Ahmed, and thank you for your time, and I apologize for extending my time.
That's fine. Thank you, Dr. Dalia. It's a very interesting talk.